This is Chapter 31, Promoting Reproductive Health, Various Gynecological Disorders. This chapter will be a lot of review as well. We've talked about some of these previously toward the beginning of the semester, so I'll just briefly go over some of these. Menstrual disorders. Remember that amenorrhea is the absence of menstruation. It's either primary or secondary. Primary occurs when menstruation has never occurred, and then secondary occurs when menstruation starts and then it stops. So it has to be at least 3 months in women that have regular cycles already, and it has to be 6 to 12 months in women that have irregular cycles. So usually there's an underlying cause, but primary is when they've never had a menstruation, and secondary is when they've had a menstruation regularly, and then it stops. So 3 months for people with regular cycles and 6 to 12 for people with irregular cycles. Abnormal genital bleeding. This can include menorrhagia, metrorrhagia, menometrorrhagia, polymenorrhea, intermenstrual bleeding, oligomenorrhea, and then postcoital bleeding. And you can look on page 979 in the What to Say box as far as patient education and what these terms mean. Dysmenorrhea. This is one of the most common gynecological problems, and it's painful menstruation. This also is primary or secondary. Primary usually occurs due to physiological causes. It can be hormonal imbalances, psychogenic factors, also an increased prostaglandin secretion. And this has an early onset. So primary has an early onset. Secondary is usually due to an underlying cause, and it has a later onset as far as their age. Vaginal infections. So bacterial vaginosis, this is actually the most common vaginal infection. It's not considered an STI. So just keep that in mind. It's the most common vaginal infection, and it's not considered an STI. A lot of times the patient may be asymptomatic, but if they do have symptoms, it'll be a white or gray discharge with a fishy odor. That's kind of a classic sign of bacterial vaginosis. They may also have pain or burning and itching. You can look at the risk factors on page 981. It shows those bullet points there. Treatment for bacterial vaginosis includes metronidazole. This would be either orally or it can be taken vaginally as well. They can have a cream, but metronidazole is the treatment. Candidiasis, we've talked about candidiasis being a yeast infection, so some people can have thrush in their mouth. They can also have a yeast infection in their vaginal area. This is usually caused by Candida albicans. That's why it's called candidiasis. Symptoms include intense vaginal itching. They also have thick white vaginal discharge. Treatment includes an antifungal medication. A lot of times these can be over the counter, like miconazole, clotrimazole. Those a lot of times are over the counter. Sometimes they may need an oral medication, which is fluconazole, but most of the time the symptoms can be treated over the counter, and then it will help resolve the yeast infection. Toxic shock syndrome. Now, this is a rare but serious condition. It's caused by bacteria that leads to toxins in the bloodstream, which then further leads to severe organ damage or even death. It is associated with the use of tampons, so it's important to educate, especially adolescents and young women, that tampons should be changed at least every 6 hours. And it's also important to alternate tampons and pads, especially at night. You may encourage them to wear pads since it's a longer period of time. But alternating with pads and then changing the tampon at least every 6 hours. Common symptoms of toxic shock syndrome include a sudden onset of fever. They may have a rash, vomiting, diarrhea, muscle aches, and hypotension. Treatment, actually they will be hospitalized, and then they need fluids and antibiotics to treat this. Like I said, it is rare, but it's a very serious condition that can lead to death. Urinary tract infections. This is very common, especially in females. Usually it's caused by E. coli, and it does occur more frequently in women. Doesn't mean it can occur in men, but just more frequently in women because of the way the urinary tract is designed in women versus in men, and then of course the proper hygiene care as well for women. Risk factors include either being really young or elderly, so their age, if they have altered immunity, if there are anatomical anomalies, if they're diabetic, if they have urinary tract obstructions, pregnancy, sexual activity, and the use of diaphragms. All of those things play a part in increasing a woman's risk for a UTI. Bubble baths and soaps can also cause irritation and introduce bacteria, so it's important to educate on those things as well. Common symptoms of a UTI include dysuria, urinary urgency or frequency, and hematuria. Treatment for this would be antibiotics. Endometriosis. So this is the growth of endometrial tissue outside of the uterus, and we've talked about this before, but you can look on page 986, figure 31-3 to see some areas where it could grow. You can also see on the slide here as well. Risk factors include early onset of menarche, short menstrual cycles, low birth weight, nulliparity, heavy or prolonged menstruation, and infertility. The most common symptom of endometriosis is pelvic pain that usually starts 1 to 2 days before menstruation, and it can be unilateral or bilateral. The treatment for endometriosis is individualized and is based on the severity of symptoms and the woman's desire for future pregnancy. So there are medication options, there are surgical options. So it does depend on how severe the symptoms are for her and whether she wants to have future pregnancies or not. Leiomyomas are also called fibroids or uterine fibroids. This is the most common solid pelvic tumor in women and the leading reason for a woman having a hysterectomy. These are most commonly located in the uterine wall, and you can look at page 988, figure 31-4. Treatment includes follow-up every 3 to 6 months if the symptoms are mild. If it worsens, and over time as they're watching this and it continues to worsen, treatment would include medications or surgical procedures. You can see the different types of surgical procedures here that they would perform for a uterine fibroid. Abnormal uterine bleeding. This is uterine bleeding that disrupts normal daily activities. So there could be several different causes for this, and they usually say, kind of to help you remember, is POM or COEIN. So POM would be your structural causes, which stands for polyps, adenomyosis, leiomyomata, or malignancy, and that kind of helps you remember those are structural, POM. And then COEIN would be your non-structural causes, coagulopathy, ovulatory dysfunction, and endometrial cause, iatrogenic cause, or, of course, you have to put not yet classified in there. So those kind of help you remember the causes for abnormal uterine bleeding. Treatment is going to depend on the cause. It could range anywhere from medications to surgery. Surgical procedures would include a DNC, or dilation and curettage. Another option would be an ablation, or it can be all the way as significant as a hysterectomy. So all of that depends on what they determine the cause is. Hysterectomy. This is removal of the uterus. So a hysterectomy can be partial, in which the upper part of the uterus is removed and the cervix is left. So that would be partial. The upper part of the uterus is removed, the cervix is left. A total hysterectomy is when the entire uterus is removed. So that's a total, the whole uterus. And then a radical is the other extreme from partial, in which the uterus, the tissue on both sides of the cervix, and the upper part of the vagina are removed. So partial is just the upper part of the uterus. The cervix remains. A total means the entire uterus. And then a radical is the uterus tissue, the cervical tissue, and the upper part of the vagina are removed. You can look at page 991, the patient education box, for different surgical approaches, because it can be abdominal, it can be vaginal, it can be laparoscopic, they can do robotic. So there are different ways in order to do the hysterectomy depending on the patient and what's going on. So that's on page 991. Ovarian tumors. Excuse me. Most ovarian cysts will disappear without treatment. They occur most often during the childbearing years, so those that are of childbearing age. And so the different types of cysts would be dermatoid, follicular, and corpus luteum. So dermatoid cysts originate from a potential germ cell. Follicular cysts usually develop during the first half of the menstrual cycle. And then the corpus luteum cysts, these form from the corpus luteum during the second half of the menstrual cycle. So it's not important that you know all about each one of these types of cysts, but understand that most of them usually disappear without treatment, and most of the time these are going to be found in childbearing age women. Polycystic ovary syndrome. This is one of the most common endocrine disorders in reproductive age women. It's when the ovaries produce an abnormal amount of androgens, which causes an irregular menstrual cycle. It also causes excessive hair growth, acne, and infertility. Risks for having polycystic ovary syndrome would be the development of type 2 diabetes, if the patient has coronary artery disease, hypertension, if they have or have had cancer, and if they have dyslipidemia. So those would increase her risk of polycystic ovary syndrome. First line treatment would be diet, exercise, and weight loss. Obviously, there are medications that would be used secondary as a second line treatment, but first they're going to try diet, exercise, and weight loss. Diseases of the vulva. So there's different ones we're going to talk about here. Bartholin's glands abscess. So there's Bartholin glands that are located deep within that posterior portion of the vaginal introitus, or that vaginal canal area. So an abscess would be a tender, painful lump or cyst that forms on that gland. Molluscum contagiosum. So remember we talked about this in children. This is different. I mean, it's the same, but it's different because this type of molluscum is spread by sexual activity in adults. So in children, it's spread by fomites, which would be objects or materials, and children have it usually, we talked about their knees, their elbows, they're different places. But when we talk about molluscum contagiosum in the vulva, we're talking about spreading by sexual activity. So remember, it's a viral skin infection. It causes that rash with those little papules, and it has a little cheesy-like substance in the center of it. It looks like you can pop it, but it's not necessarily good to pop because they will go away on their own, but it does take a while for it to go away. We talked about different treatment options for the non-sexual spreading when we talked about the children. Then vulvar condylomata, let me say that again. This is a growth that resembles a wart on the mucous membrane, usually on the genital area or the anus. Recurrence is common and is spread by physical contact. And then there's 3 at the bottom here, the lichen simplex chronicus, the very first one there. This is kind of an eczema condition characterized by scaling and intense unrelating pruritus or itching. Lichen sclerosus is an autoimmune inflammatory disorder, and lichen planus is an autoimmune inflammatory mucocutaneous disorder. So just kind of be familiar with these disorders of the vulva. And what is the nurse's role? So what do we do as nurses as far as women's health and making sure that they are, taking care of themselves in the right way? So we want to encourage them to be aware of common irritants and allergens that may be irritating to the vulva. We want to reduce the risk of irritation and infection. And we can teach them, remember, to wear cotton underwear, to keep the area clean and dry, to avoid douching because that can get rid of our normal bacteria, and to perform vulvar self-examinations so that they are aware of things that need to be reported to their healthcare provider. And that is the end of chapter 31.